Now moving on to our next set of diseases, that is vesiculobullous lesions. Vesicular, more simpler, this algorithm is more easier, and the textbooks also have an algorithmic approach. So many people will be familiar with this application of this, because it is basically either the algorithm can be devised along the level of the split or the type of inflammatory infiltrate involved. Okay. So we'll run through this. So vesiculobullous lesions, we are seeing here subcorneal level of split. It could most probably, then if there is eosinophils and a little amount of sponges is there, most common disease subcorneal level of split is pemphigus foliaceus. So we all know it is pemphigus foliaceus. Closer look, mixed inflammatory infiltrate, eosinophils and neutrophils will be seen of pemphigus foliaceus. What is this? You all would have guessed already. Then it is a suprabasal bulla with those tombstones that you're seeing, a remnant of basal layers, basal cells. It's a suprabasal bulla. So it's pemphigus vulgaris along the basal layer. So if you see, you can see this inset picture. You can see the. I'll just replace the pointer. Okay, where's the pointer here? Okay, there is these what have been highlighted in the inset. There is basal layer that is there preserved along. So it is called the preserved tombstones whenever it is dislodged. There's some amount of acantholysis as well here. So it is pemphigus vulgaris. See, you can acantholysis, you can see these are acantholytic cells. These are the remaining basal cells over here. And this is a case of pemphigus vulgaris. So here, this is again, there is suprabasal bulla or intra-epidermal sort of, or it is basically suprabasal. But what we have to see here is there is epidermal hyperplasia. That is acanthosis, extensive acanthosis. This is commonly seen in. With acanthosis, you are seeing a bulla of suprabasal bulla. It is commonly pemphigus vegetans. There are so many variants in this. I'm not going to details of that. Pemphigus vegetans, you're seeing suprabasal bulla with hyperplasia of the epidermis, hyperkeratosis, acanthosis, etc. Now we are seeing what you are seeing is the acantholysis lysis is striking here. Again, the level of split is suprabasal, but the acantholysis is striking. This is nothing but Haley disease, what we call as a dilapidated big ball appearance. There is acantholysis depicting a dilapidated big ball appearance, and there is suprabasal full. There are some more diseases with suprabasal bulla with extensive acanthosis, and you have carcin rods or grains, what we call. This is seen in Darier's disease. You can see these grains here, carcin rods over here, and grains over here. Okay, this is nothing but Darier's disease. Again, the separation is this can involve the face, and a very disease which is very grievous and very altering the dysmorphic. Yeah, that is, it can create a very dysmorphic image of the patient actually. Now again, there is something else. What you have to observe is there is no epidermis over here. So it is the entire epidermis is separated, and you are seeing striking pink color. So there are a lot of eosinophils in this space. So here it is a sub-epidermal bulla. Sub-epidermal bulla is bullous pemphigoid. Bullous pemphigoid is eosinophils over here also, eosinophils over here. Not much acantholysis like you saw in the previous entities. Bullous pemphigoid. This also is subepidermal bulla, but what is there here is neutrophilic abscess in the papillary dermis. This is a very typical lesion. Here, clinical history also becomes important because there is gluten hypersensitivity. Here, those is dermatitis herpetiformis. Okay, dermatitis herpetiformis is it's a fairly common disease among young children with IgA, immunofluorescence, etc. positivity. Okay, papillary dermis, there is neutrophilic abscesses. So now we have a similar subepidermal bulla with neutrophils and eosinophils admixed, or lymphocytes and neutrophils admixed, and throughout there is a hemorrhage or there is a separation. Okay. This is linear IgA bullous dermatitis. The linear IgA bullous dermatitis, you have lymphocytes in too many lymphocytes over here as well as, and nothing in the dermis. So another picture, closer look of linear bulla. So neutrophils and lymphocytes predominantly, less of eosinophils like dermatitis herpetiformis, but separation is far more exaggerated. Now, what are we seeing here? Now, what are we seeing? There's a subepidermal bulla, and there is festooning of the dermal papillae over here, and it is nothing but porphyria cutaneous tarda. Okay, there is a typical festooning of the dermal papillae with lot of blood vessels over here. Lot of blood vessels over here. This is porphyria cutaneous tarda. Okay, so now we come to these mechanobullous diseases, that is epidermolysis bullosa simplex, epidermolysis bullosa simplex, where the inflammation is very minimal, acantholysis is very minimal, and there is separation or sub-epidermal. Most common is epidermolysis bullosa simplex. There are a group of this can be genetically mediated also. So there is basically this is minimal inflammation bullous disorders. If you want to say, first thing that should come to your mind is epidermolysis bullosa group of diseases. Now coming on to the algorithm of vesiculobullous reaction pattern. We just were able to see few lesions based on the level of the split, and likewise we see we can deduce an algorithm. So vesiculobullous lesions, intracorneal and subcorneal, intra-epidermal, suprabasal, and subepidermal. Pemphigus foliaceous, intercorneal most commonest. See, just you have to observe this. Pemphigus foliaceous split high in the granular layer or beneath stratum corneum with neutrophilic or eosinophilic spongiosis. Split high in the granular layer or beneath the stratum corneum. So subcorneal bulla or intercorneal bulla or within the granular layer. Now, as furthermore, intracorneal subcorneal, there is IgF pemphigus. So subcorneal pustular type, the dermatosis type, subcorneal pustules with acantholysis, subcorneal pustular dermatosis, pustule sitting dermatosis. It's also called as pustule sitting dermatosis because there is no epidermal indentation. Next, you have staphylococcal scalded skin syndrome, rare to find an intact blister. So usually epidermal will be peeled off with a neutrophilic exudate. So these are all come under the category of intracorneal and subcorneal bulla. Now, coming on to the intra-epidermal, there are a list of diseases here: spongiottic blistering diseases, where allergic contact dermatitis, pompolix, PMLE, insect bite reaction, incontinentia pigmenti, all are grouped here. There are subtle variations or subtle details here, but all have spongiottic blistering diseases, but they are intra-epidermal pustules. So allergic contact dermatitis can have eosinophils. Pompolix clinical history becomes very important because it is palms and soles involving. PMLE, again, sun-exposed areas. Insect bite reaction is incontinentia pigmenti is vesiculobullous with eosinophils. Okay, eosinophils with pigment incontinence, and children, it's a genodermatosis. Intraepidermal, palmar pustulosis. Palmoplantar pustulosis is another intraepidermal blistering disease. Viral blistering diseases are also important. That is herpes simplex skin, say inclusions, herpes zoster, and varicella. All these come under viral blistering diseases with, of course, the margination, molding, nuclear margination, etc., etc. Clearing of the nucleus, all these can be seen. Suprabasal, pemphigus vulgaris, acantholysis with adnexal involvement. Pemphigus vegetans, we saw this picture, acantholysis with or without new eosinophilic microabscess. Hyperkeratosis with acanthosis and dermal lymphocytes. Genodermatosis, Haley or Darius disease. Grover's disease, transient acantholytic dermatosis. So genodermatosis, we saw Haley and Graves disease. Grover's transient acantholytic. These are all subepidermal, suprabasal or suprabasal bullous disorders with Haley having a dilapidated brick ball appearance, Darius having coarse rods and grains, Growers having transient acantholytic dermatosis. Minimal inflammation, we already know about this. Epidermolysis bullosa, it's basically mechanobullous. Porphyroacute tarda, very minimal inflammation, preserved dermal papillae, festooning, and then with eosinophils, you're seeing subepidermal bullous pemphigoid is a lesion. With lymphocytes, it can be erythema multiforme. With neutrophils, it can be dermatitis herpetiformis or linear IgA dermatosis. So we have quite a few groups of diseases here. So many pemphigus foliaceous here. You have to concentrate where is the split and what is the type of inflammation. IgF pemphigus, this is a little rare. Subcorneal pustular dermatosis, what is the characteristic feature? It is a pustule sitting dermatosis. Staphylococcal cells, entire epidermis can be necrotic. Spongiottic blistering diseases. So many entities are the spongiottic blistering diseases. Okay. Then you have palmoplantar pustulosis. Then we have these herpes blistering diseases. Then we have suprabasal bullae with pemphigus vulgaris, acantholysis and adnexal involvement, and pemphigus vegetans where there is epidermal hyperplasia with microabscess, etc. These genodermatosis also you should remember. Here clinical history becomes important because they have an area predilection. Growers, Darius, etc. Darius can involve face, but Haley growers, etc. can usually involve axilla. Usually involve axilla, groin, etc., etc. Okay, Grover's disease, you have epidermolysis, minimal inflammation. Once it is minimal inflammation and sub-epidermal, you have to think of epidermolysis bullosa. Epidermolysis bullosa. Porphyrocutinate tarda with festooning. Whenever you use morphology, preserved dermal papillae festooning. Mechanobullous diseases with minimal inflammation. Porphyrocutinate tarda will be there'll be prominent blood vessels in the dermal papillae. So bullous pemphigoid, eosinophils again. So porphyrocutinate tarda, epidermolysis bullosa, mechanobullous diseases, eosinophils, bullous pemphigoid with lymphocytes, erythema multiforme. And when you're seeing neutrophils, it is either dermatitis herpetiformis or linear IgA bullous. So all these form various your vesiculobullous diagnosis, which you can again narrow down. Again, level of split. This I think most of you would have already figured out because it is in the standard textbooks. The algorithms, it's an algorithmic approach in the standard textbooks as well. Okay.